A very big hello to all my dear students. So let's today start with glaucoma. It's a very important topic. So what is the term glaucoma? As discussed earlier also, that glaucoma, please don't learn, is just increase intraocular pressure, right? So you may find many cases where the pressure is not increased, but still there is damage of the optic nerve. Keep in mind, when we talk of glaucoma, it is some particular pattern of damage of the optic nerve. It is that simple. Anyway, we are going to discuss all in and out about it. So let's start with glaucoma. Our first heading will be formation of aqueous humor. All of you right? Formation of, and do I need to remind you all again? If yes, okay, I don't mind doing that. Please don't forget that you have to learn in the class here itself with me. It doesn't matter it's a recording or I'm live, I'm always available for every queries. And whenever you are studying with me here, you have to make your notes very seriously because you're going to benefit in proportion to that. What was the second point I had told you earlier also? Qs and double Qs. So wherever I am going to mention a Q, it has been your exam question and you should be seriously taking it and putting a Q on your copy. Right? I think it's clear? Okay. So let's start with formation of aqueous humor. So we give the heading formation. So everybody knows, have we learned this? When you say formation of aqueous humor, give the heading please. We all know that aqueous is formed from the ciliary processes. Let's draw together all of you. If you talk about the ciliary process, this is a single ciliary process, right? And then these are the blood vessels. This becomes your stroma, right? And there are two layers of epithelium. The one which is inside is pigmented. We are saying this is your pigmented epithelium is this one, right? And outer is your non-pigmented epithelium. I'm repeating, so this is a single ciliary process. You all know that aqueous is formed from the ciliary process, right? So this is a single ciliary process with these blood vessels, stroma. This is, please label this as non-pigmented epithelium, and we are going to draw here pigmented epithelium. Label it pigmented epithelium. Okay. So what is very important to understand? Where is the aqueous formed? From which cell majorly the aqueous is formed? It is the non-pigmented epithelium. Right? So, little bit more about alignment of pigmented and non-pigmented and how the aqueous is formed. Write down. All the three processes are taking place. Diffusion, let us write it together. Ultrafiltration and secretion. And secretion being the energy dependent process. So this non-pigmented epithelium has got sodium potassium ATPase pump, and this is responsible for the process of secretion and formation of aqueous humor, right? But everything is taking place: diffusion, ultrafiltration and secretion. Okay, so if we are clear about from where the aqueous is formed and what are the processes involved, important question: which process is responsible for maximum formation of aqueous humor? So what will you answer? Which process is responsible for? So we'll put a Q here. Maximum aqueous is formed by secretion. So the maximum amount of aqueous is formed by secretion. Correct? Okay. So once we know this, let's have a look at the slide. So we have to also understand one very important point here, that both pigmented and non-pigmented epithelium, I'll just show you the slide, they are aligned apex to apex and there can be a free movement of the electrolytes and water across it. Okay, so that is one important point here. But when you talk about non-pigmented, that's why sodium potassium, so it has non-pigmented has tight junctions. So it is actually a part of blood aqueous barrier. So we'll write one by one. First of all, let's have a look at this. This is your single ciliary process. We have made the blood vessels, right? Arteriole and venuole, can you see that? And stroma of the ciliary process is this one. Now we are clear. There's a pigmented is inside and non-pigmented is this one, right? And there's internal limiting membrane. Now, I was talking about, so this is again a very clear slide where these are zonules, this is the lens capsule and how it is attached to the ciliary process, and these are the two layers of epithelium. I hope you will appreciate and things will be more clear where I am, what I am talking about, which ciliary process, kahan tha. So I think everything is now clear to you. Do we really understand that what is the direction of movement, what is happening? It is the aqueous is filtered from the blood through the stroma for pigmented, non-pigmented, and it comes into the posterior. This just for your understanding. If you want to just learn the point is here, please remember majority of the aqueous is formed by secretion. Okay. If we know this much, we talk about another very important thing, and this secretion of sodium, potassium, ATPase pump, you have to know that this is mainly very helpful for the larger solutes which cannot just pass passively. It is mainly for the larger solutes. Okay. Come to the next important point. What is the rate of formation of aqueous humor? Let us note down. So rate of formation, this is also exam question, all of you. Let us put a Q here. Rate of formation of aqueous humor, we will learn it as 2.3 microliters per minute. It is 2.3 microliters per minute. Okay. Come to the next important thing is, we have understood in our introduction only that how the aqueous is flowing and how it is the impaired drainage which can lead to more amount of aqueous that can raise the pressures and that can lead to damage of the optic nerve. Correct? So we can understand this, that actually what is the main crux here? So you remember na, what we will talk about the outflow shortly. So what is the main crux here is that it is the more amount of aqueous which is causing more pressure leading to glaucoma, because majority it is more pressure, and why in some cases pressure is not a factor, we'll just talk. So I just want to mention a term here. Majority of the aqueous problem, when there is more amount of aqueous, it is due to less drainage. But there can be a condition where more aqueous is formed. So when more aqueous is formed, we call it hypersecretory glaucoma. Right? So what is hypersecretory glaucoma? When more aqueous is due to increased formation of aqueous humor. It is not due to less drainage, it is due to more formation of aqueous. We call it hypersecretory glaucoma. The question they have asked you, all of you make a Q here. In which condition do you get this? So I hope you remember your PSM part. It is epidemic dropsy. We'll answer epidemic dropsy. Right? So that was another important question related to formation of aqueous. Okay, so let's talk a little bit more about aqueous. What are things it's very important for us to know? Aqueous humor. What is the volume of aqueous humor? We will learn it as 0.31 ml. Okay, so this is the total volume of the aqueous humor is 0.31 ml. Now, some part is in the anterior chamber, majority of course, that is around 0.25 ml is in the anterior chamber and 0.06 ml is in the posterior chamber. Now this aqueous, what is the refractive index? Next point to remember regarding aqueous, it is 1.33. Please remember both aqueous and vitreous humor, the refractive index is same, that is 1.33. What is the next important thing? Aqueous constituent, 99% is water. Okay. What we will learn here next is, what are the constituents which are more than plasma? Now this can be important. So what are the things which are more than plasma in aqueous? Right? Think yourself. When you talk about the lens metabolism, you have learned with me, it is primarily anaerobic. So what happens when there is anaerobic glycolysis? It is the lactic acid formation. So this lactate formation is more. That's why in aqueous, what is more than plasma? Number one we will learn is lactate. Make sense? Okay. Come to the next thing which is more in plasma. It is the specific carrier system, right? Receptors in the ciliary epithelium, because of which the second thing which is more is ascorbate. It should be, it's an antioxidant, right? So vitamin C or ascorbate is again more. There are specific receptors in the ciliary epithelium for this. We next talk about is chlorides can be more. We will learn this together. And fourth, learn with me, pyruvate can be more. We don't need to know, just the important ones should be kept in mind, right? And don't forget about your lactate, right? And ascorbate. These two are very very important, lactate and ascorbate. Okay, so once we know this one, when I just mentioned the term blood aqueous barrier, so the free flow between the constituents cannot happen between the blood and aqueous this way. There is always a barrier. So what are the barriers? What are the places which act as a blood aqueous barrier? You have just learned with me. One is tight junctions between non-pigmented epithelium. And what is the second? It is the vascular endothelium of the iris, right? So what, just first write it, I'll explain you. Note it down. What is blood aqueous barrier? Let's write it together. What is blood aqueous barrier? We will say blood aqueous barrier is, first of all, non-pigmented epithelium, the tight junctions, right, of non-pigmented epithelium. And second we will note down is vascular endothelium of iris. That's what I said. Look here. Let's note it down. It is vascular endothelium of iris. Right. Once we know this much, I was supposed to explain. Vascular, if you remember, I think uveitis is one chapter we learn very nicely in our MBBS as well, isn't it? It's comfortable chapter to learn. So you must have learned about aqueous flare, right? So why it happens? Because aqueous flare, why will this happen? Because of the breaking of the blood. There is increased capillary permeability in the iris due to inflammation. Inflammation is causing more permeability, leakage of larger molecules, that is protein, and that is causing aqueous flare. So uveitis is causing what? That inflammation is causing what? Breaking of the blood aqueous barrier. So because whenever the capillary permeability is more in iris, it will be, so you can note down here so that we don't forget that in uveitis, there is the aqueous flare is due to breaking of this blood aqueous barrier. Done, all of you? Breaking of blood aqueous barrier. Correct. So I write with you so that's comfortable for you to make the notes. Once we know this, next we talk about is outflow of the aqueous. Now this is a repetition and I really expect you to be very comfortable answering this. So what are the major two outflows? Conventional is the major one. Second one is uveoscleral. Right? Let's note down together. So the next heading is outflow of aqueous. Outflow of aqueous. Let us divide it into two. Please note down more in the charts, in flowchart form. More should be written point-wise. More diagrams should be made and more. It should be always diagrammatic learning. Then you will learn much better. Why? Because of that picture memory. Okay. So whenever I make it, I'll make along with you. I'm not asking you to make it yourself. So whenever I draw for you, please draw together with me. Okay. So outflow of the aqueous, we will write here conventional outflow and uveoscleral outflow. Conventional, 90% of the outflow is conventional, 10% uveoscleral. Now one by one. So when you say conventional outflow, what is the other name? What do we are talking about? Through the trabecular meshwork. So we are saying we are talking about trabecular outflow. Okay. One by one. First is what is conventional outflow? We will draw and understand this. I'll show you the slide also, but let's draw for ourselves. So if this is your eye, simple representation here, no complication, right? So these are the ciliary process. Aqueous is formed from here going into the posterior chamber, through the pupil to the anterior, and from the anterior, where is it going? It is coming to from the anterior, it is going to the space between the iris and the cornea. And what is the space between iris and cornea known as? Angle of anterior. What are the structures here in the angle? I think we are very clear. It passes through the trabecular meshwork, then Schelm's canal, right? And we have learnt here, from the Schelm's canal, Where will it go? Let us learn further. We had learned about trabecular meshwork in Schen's canal already. Now we will learn that from the Schen's canal it goes to the collector channels. Okay? From in the sclera. So Schen's canal, where is Schen's canal? Right? This is a section, right? Let me show you the slide first. 1 minute. Before we draw, let us be clear what we are trying to talk to each other. Let me be clear. So we've seen this. So this is your outflow. Can we see it here that this is the posterior chamber? Aqueous from here, how through the pupil is coming into the anterior chamber. Right? From the anterior chamber, this is the angle. Here is your trabecular. Outflow means this is the trabecular meshwork. Right? And from here, this is more clearer. This is showing you how this aqueous is going from here to the Schen's canal. This one is labeled as Schen's canal. There are collector channels in the Schen's canal. From there it can go to aqueous vein of Asher. We will write it together. Just let us see in this slide first. From that aqueous vein, it will be reabsorbed. So it is filtered from the blood and it is reabsorbed in the blood. Not a big issue, right? So it will be reabsorbed in the episcleral venous system. Okay? What will happen after that? Chalo, let's write and understand what will happen. But Schen's canal, overall in the eye, if you're looking at my eye, where do you think is the angle? What is angle? We had explained it in the introduction part. If anybody has not seen that introduction part, please see that first before learning any chapter. So we know that it is the angle is corresponding to limbus from outside. So where will be the Schen's canal? It is just outside. Angle and this one. Now I think it should be very clear to you from this slide. This because we generally make in sections, so sometimes we get confused. So I think now it is clear to you that this is where the Schen's canal. Very nicely depicted here how the aqueous is formed, going into the angle, coming into the Schen's canal, and it is reabsorbed in this episcleral venous system. Right? Now you are clear? If you are clear, now we can at least write. No use writing if you are not clear. So we were talking about from the Schen's canal, we will write here, it is going to the collector channels of in the sclera. Okay? And from the collector channels in sclera, let us note down here, channels in sclera. Should I write up here? You can just note down in your copy horizontally as well. It will go to aqueous vein of Asher. ASCHER, okay? So from there, of course, episcleral venous system. So we have learned two additional things here, right? And from there to episcleral venous system. Where will it go after that? From the episcleral venous system, can you think of what is the venous system? Where will it drain? Of course, superior and inferior ophthalmic vein. Keep writing. So it will go through superior and inferior ophthalmic vein. Which will drain into cavernous sinuses, right? So this will drain into cavernous sinus. Are we supposed to think something here? Venous drainage going till cavernous sinus. Any pathology in the cavernous sinus can cause more pressure in the episcleral venous system. When there is more pressure in the episcleral venous system, that becomes another important cause of glaucoma, right? So that becomes the post-trabecular cause of glaucoma. We'll talk about it when I'm discussing secondary glaucomas with you all. Okay, so this was about the trabecular outflow. One more important and interesting thing, trabecular outflow is intraocular pressure dependent. Okay, so when I say this, I go back here, we can write this point here, IOP dependent. More the IOP, more there will be, it can increase with increased IOP. So it's an IOP dependent process somewhere. But when you talk about uveoscleral outflow, this is, write down here, not IOP dependent. This one is not IOP dependent. So that's another important point here. Now when we talk about uveoscleral outflow, correct? Let's talk about that as well. So when you say uveoscleral outflow, common sense, so uvea is the sclera. Instead of taking such a long route, I am smart enough, Let me cross the uveal tissue. Let me cross the uveal tissue and the sclera, right? And through the suprachoroidal space, I am going to finally get absorbed in the blood system, right? So that is what is uveoscleral outflow. Let's have a look at the slides. Yeah, let's see this slide. What do you see here? What is uveoscleral outflow? Through the uveoscleral is crossing the uvea and the uveal tissue. This is going to go into the suprachoroidal space. So it is, I think our diagram is even more explanatory here. So let us draw in that diagram, crossing the uvea, crossing the sclera. And from the sclera, note down, right here. So this one is depicting our crossing the uvea and sclera, and then it reaches the episcleral venous system. How? Venous system, either it is generally reabsorbed through the sclera or going through the suprachoroidal space. It will be reabsorbed through long posterior ciliary artery. Okay? So long posterior ciliary vessels, it will be reabsorbed. Let us note it. If you have written here, what are you writing? It is going from uvea to suprachoroidal space. Okay? Root of iris, or from the uvea, from where? From the root of iris. So from the root of iris to the suprachoroidal space. Okay, and from there, either it is, as I said, absorbed in the sclera through the pores, or going through long posterior ciliary, absorbed in long posterior ciliary vessels. What are long posterior ciliary vessels? Have I discussed? We will discuss it more in detail in uveitis. Okay, that was about your uveoscleral outflow. So when I am talking about outflow, very quickly, it can be conventional or uveoscleral. Now, how do you measure the outflow? What is that term called? This is your exam question, guys. We'll make a Q and learn. What is facility of aqueous outflow? Can we write here? I'm writing the Q here. What do you mean by facility of aqueous outflow? So facility of aqueous outflow, it is nothing but how we are measuring how easily the aqueous is flowing through the outflow system, right? So it is generally, what is that term called? That method of measuring, this is what is called tonography. So this was your exam question. They have asked you, it's a repeated question actually, double Q, that what is tonography? Tonometry, we all know, is measuring the intraocular pressure. And when we say tonography, it is measuring the facility of aqueous outflow. How do we do it? We actually, details will not be asked to you, but we take an electronic shiots and continuously measure the pressures for 4 minutes to find out the outflow. Anyways, next important thing that you have to know, it is depicted by C value, which is 0.22 to 0.28. This value you have to remember. This is to be learned. 0.22. So what is the facility of outflow? 0.22 to 0.28 microliters per minute per millimeters of mercury. Right? Depicted as C value. Great. So that was about the aqueous outflow. Now, before moving further into the topic of glaucoma, I think everybody has been learning and listening about open angle closure. What does this mean? What do you mean by open angle and what do you mean by angle closure? Very simple. We will draw this. To understand, let's draw quickly. See, whenever, okay, I'll repeat this what I just said, that majority of the times more pressure is the cause of glaucoma, and more pressure in majority of the time is due to more amount of aqueous, and that is majorly due to less drainage. When you say open angle or angle closure, we are discussing the type of less drainage, or blockage in the drainage can be of two types. So this less drainage can either be because this space, this time to understand here, okay? Because this space from between the cornea and iris, which we call as angle, this is obliterated. So any cause where this is obliterated is angle closure. When the aqueous which is formed here is not able to reach the angle at all. It is angle closure. Correct? Now think yourself, but suppose there is another scenario. The aqueous is flowing easily, angle is open, it reaches the angle, but now there is blockage in the trabecular meshwork. So angle is open, the space is not obliterated, but there is a blockage in trabecular meshwork. This is what is open angle glaucoma. Correct? So we are talking about different type of impaired drainage here when we are talking about either open angle or angle closure glaucoma. Let's see some slides. Okay, so let's see the slide here. What do you see here? That if the aqueous is flowing out nicely and is reaching this space, this is open angle. But due to any reason, and major reason is pupillary block. Whenever there is a pupillary block, suppose here in this case the lens is touching the iris, there is a pupillary block, aqueous cannot flow, it will collect in the posterior chamber, it pushes the iris forward, blocks this angle, this is closed angle. So now if you have understood this, that what is open angle and what is angle closure, we can talk about glaucoma. Before that, a few points about trabecular meshwork that we have to keep in mind. So when you are saying that conventional outflow, it is going through the trabecular meshwork, we will additionally know here that trabecular meshwork has three parts. Okay, so the trabecular meshwork has three parts. What are the three parts? Look here. What do you understand here? So if this is the trabecular meshwork section, these all 1, 2 and 3. These are the three parts. This is the angle, this is your sclera, this is the cornea, right? So here is the iris here. Understood? Iris, cornea, and this is the space where the TM is there. TM is trabecular meshwork. Can you see here there are three parts. More towards the iris, this is uveal trabecular meshwork, then comes your corneoscleral, and then comes your juxtacanalicular. So juxta means beside. It is beside the Schelm's canal. So juxtacanalicular. It is also showing you that this is here is your Schelm's canal. This one is your Schelm. This orange one is Schelm's canal. If we have understood this, let's write it. So first point about trabecular meshwork that we will remember, that it can be either uveal, corneoscleral or juxtacanalicular. Okay. Next we talk about is time to discuss one very important exam question here. Among the three, where is the blockage maximum? Where is the maximum resistance happening in trabecular meshwork? You just learned with me, na? Open angle, it is a blockage in trabecular meshwork. Now our question is, which part of TM will cause maximum resistance? Please remember, it is juxtacanalicular. This causes maximum resistance. Okay? So this will lead to maximum resistance is caused by juxtacanalicular trabecular meshwork. Also we will keep in mind that when these channels secrete glycosaminoglycans. Why it is important to learn this? GAG. Everybody knows what is GAG? Glycosaminoglycans. So this we are saying that it secretes glycosaminoglycans. Apply it yourself. We know that when we have learnt in our lens chapter as well that the most common complication of steroids in eye is glaucoma. So this steroid induced glaucoma is primarily due to increased in secretion of this GAGs or increased deposition of mucopolysaccharides. Okay, you want to note down? Please note this down. Okay, then we come to the third point about the trabecular meshwork we will know is it has got actin and myosin, right? This contractile property of TM or trabecular meshwork is due to this actin and myosin. So we will say it has contractile property and this contractile property is due to actin and myosin. Written? Okay. Right? Again, can we apply this information somewhere? Any question? Yes. So when we will be talking about, we will again talk about this anti-glaucoma drug, the recent one being nitarsodil. So nitarsodil is mainly increasing the contractile property of trabecular meshwork and increasing the trabecular outflow. Okay, so we are going to learn about nitarsodil. We will hold it here. Let me tell the details when I discuss treatment. Okay, so once we have done this with the basics, so till now what you have learned with me is how the aqueous is formed, what is the rate of formation, what do you mean by hypersecretory glaucoma, what is the outflow of the aqueous, how the aqueous is drained. We know that majority of this more pressure is due to more amount of aqueous. What do you mean by open angle glaucoma and what do you mean by angle closure? ठीक है यहाँ तक? चलो. Now we define glaucoma. Everybody till now knows very nicely that you will not define glaucoma as more pressure. So how we are going to define glaucoma? Let me first explain before you write. Particular pattern, a particular morphological pattern में there is damage in the optic nerve, and majority of the times it is the intraocular pressure, which is the major modifiable factor. ठीक है? Let's note it down now. So when you say glaucoma, please, I have got this for you here, but you don't have to mug up anything, right? You have to just understand. Anyway, you're going to attempt only MCQ type question, but still, what you need to know, it is a chronic progressive optic neuropathy, and in a particular characteristic morphological changes in the optic nerve head and also in retinal nerve fiber layer. Actually, why we have written here, this is the latest, because even this keeps changing. This is one of the latest definition given in your 9th edition of Kansky. So let us follow this. So it's a group of conditions that have in common a chronic progressive optic neuropathy that results in characteristic morphological changes at the optic nerve head and in the nerve fiber layer. Don't forget, IOP is a key modifiable factor. Correct? Okay. So now once we know what is glaucoma, what are the mechanisms by which there is optic nerve damage? We will learn together. There are two major mechanisms. I have already mentioned. One, when it is due to more pressure, what is that theory called? Mechanical theory. So the damage can be due to mechanical effect due to more pressures. That is your mechanical theory. More IOP is causing mechanical damage of optic nerve. Correct? Written? And second is your vascular theory. So there are cases where our IOP is normal. That is explained by vascular theory, that it is the less blood supply in the optic nerve which can be a cause of glaucoma. Okay, so once we know these two mechanisms, next heading is classification. Okay, talking about classification, glaucoma is again classified as congenital, which is also called developmental. I hope you know developmental means still adolescence and congenital is from birth. So we will subdivide it. So write down congenital or developmental glaucoma, and second is your acquired. Simple. When you say congenital, we further divide it as true congenital. True congenital means the child is born with the disease. Infantile. Now normally we know that infant is 1 year age, but here we will learn any glaucoma in less than 3 years of age is infantile. So less than 3 years of age. Less than 3 years. And juvenile is from 3 years to adolescence is juvenile. And very interesting and important fact here, that the sclera within the 3 years of age is very soft. So whatever more pressure that is rising in the eyeball, that is causing stretching of the sclera and expansion of the eyeball. This is what is called buphthalmos. So what is buphthalmos? Expansion of the eyeball, and it is synonymous with true congenital glaucoma or with infantile glaucoma. ठीक है? Okay, so then we talk about acquired. Let us write for acquired. Make it simple here. So acquired glaucoma, it can be either way you can write. Either first you write about primary, secondary, or you may even say open angle or angle closure that we learned. So anyway, let us write like this. It can be primary or secondary. Everybody knows primary means we do not know the cause and secondary means we know the cause. Right? So primary, again this can be either open angle or angle closure. So primary open angle glaucoma is written like this, POAG, or primary angle closure glaucoma. So when you say POAG, we'll discuss few more things here. It can be primary open angle glaucoma. We will talk about what is ocular hypertension. We will talk about normal tension glaucoma. This is what OHT is ocular hypertension and NTG is normal tension glaucoma. Right? Then we talk about PACG, angle closure. Now what are the mechanisms? Generally it is either with a relative pupillary block or it may be some other reasons, right? Which is combined mechanism. So it can be either a pupillary block, right? Or some combined mechanisms. So it could be, we'll discuss here about plateau iris and all as we reach to this topic. Then when you say secondary, the secondary again you can divide it into open angle and angle closure, right? So secondary is also divided into secondary open angle glaucoma and secondary angle closure glaucoma. Again it can be closure, again is simple, it can be either with pupillary block or without. Let's make it simple. Here also you can write it like this. Either it is with pupillary block or it is without pupillary block. With pupillary block or without pupillary block. PB is pupillary block. Similarly, secondary angle closure. Again with pupillary block or without pupillary block. What about secondary open angle? This we further divide as what are the factors that is secondary open angle. Think yourself, common sense. We already know what is open angle. Okay? So blockage of trabecular meshwork, secondary means what can be the other causes. It could be pre-trabecular, trabecular or post-trabecular. We will learn the details when we discuss secondary glaucomas. As of now, if you want to write it, you can further make it as pre-trabecular. Should I write it on the next page? Chalo, यहाँ लिखते हैं secondary open angle glaucoma. It can be pre-trabecular, trabecular or post-trabecular. Right? So you just remember, this is the basic classification where we will move one by one. Right? Now we talk about, so once we know this, we know the mechanism and classification. Next is, give the heading primary. So one by one we will start with primary open angle glaucoma. Right. Let us talk about risk. When you say primary, you do not know the cause. And when we don't know the cause, we learn the risk factors. Please remember the risk factor of primary open angle is very important for exams also. We will put a Q here. We will not take it lightly. So what are the risk factors? Very important, first what needs a mention is intraocular pressure. Right? A high IOP is a very big risk factor for the damage and glaucoma. We all know that. Or difference of IOP between two eyes of more than 4 millimeters of mercury. Difference of more than equal to 4 millimeters of mercury between two eyes. Right? We can remember this. Number 2, any age above 40 years. Then number 3, positive family history. Very, very important. When you talk about family history, this is time we will discuss the genes. So what are the genes responsible for glaucoma? Again, exam question. There are multiple genes. There are more than 20 loci in the human genome. What we will remember are few important names, and this has been a Q as well. So what are the genes responsible? Very important, myocilin, two names which you shouldn't forget, and optineurin. Myocilin, optineurin. So this is what gene? This is myoc gene and optineurin, OPTN. We call it OPTN gene. And very recently, one more if you want to remember. Even if you don't, it's okay. So which is the one more if you want to remember is WDR36. This is some recent finding. So this is also the gene which is responsible for glaucoma. But as I told you, this is more than that. We have to remember only these terms. And of course, let's make a cue here, please. This has been asked. Optineurin, myocilin have been exam questions. What is the next factor? The next factor would be high myopia. What is high myopia? You'll know. Any myopia of more than 6 diopters. And now when I requested you to first write this, remember it is not everything I'm going to tell in sequence, but this one is in sequence. Most important is intraocular pressure. Second most important is any age over 40 years. Positive family history, high myopia. Okay. Now, then we can write about race, right? This is more common in blacks. What about diabetes? We have been learning since so many years. We have been writing in the class that diabetes is a factor, but very recent finding that there is no increased risk of glaucoma in diabetes mellitus. Please note down in some different color. It's an important information because this is a change in the recent. So in recent finding, diabetes mellitus, which we have been learning as a factor, we are seeing that it is not a major risk factor. So you can note down no increase in risk for glaucoma. No increased risk of glaucoma. Right? So keep this in mind, please. This was about the risk factors. We next talk about is, we are talking about primary open angle glaucoma. Just discuss the risk factors. What will be the next thing? Pathogenesis. Note down, what is the pathogenesis? We were saying any mechanical cause or the vascular cause is going to lead to decrease in the exoplasmic flow. That is going to compromise with nutrition. There can be oxidative injury, and that leads to apoptosis of retinal ganglion cells. What will happen? Definitely there will be damage of the optic nerve. Now when there is thinning of the optic nerve and damage, what next happens? When there is a thinning of the optic nerve, right? Apoptosis of ganglion cells is causing thinning of optic nerve. This is clear? Do you realize what will happen? The glial cells around will proliferate. What are the glial cells there? Majorly it is astrocytes. So astrocytes and other glial cells, proliferation is taking place now. So this astrocyte and glial cell proliferation, primarily it is astrocytes. So this proliferation will lead to other glial cells. Astrocyte is also a glial cell. Everybody is clear what is glial cell? No? All the supportive cells of the neuronal system. That is your glial cell. So when there is a proliferation, this is causing alteration in the extracellular matrix of the lamina cribosa. Okay? So when there is alteration in extracellular matrix of lamina cribosa. Everybody knows lamina cribosa. We had learnt it initially only. It is part of sclera at the optic disc, which is sieve-like, right? So this, whenever there is modulation here, so there will be some alteration there is leading to main cause of cupping. This is the reason there is cupping due to remodeling of lamina cribosa, remodeling of the optic nerve head. Okay, so when there is alteration in the extracellular matrix, there is remodeling in the optic nerve head. That is where there is optic disc, and this remodeling is the cause of cupping of the disc. Okay? This is the pathogenesis we'll understand for open angle glaucoma. We learned the risk factors, we learned the pathogenesis, right? So coming to clinical features. Let us remember there is not much visual problem in a patient of glaucoma, open angle glaucoma specifically, right? This is the reason it becomes even more important for a regular checkup for all the patients who are at high risk, like positive family history. We talked about high myopia, we talked about more pressures. So why it is very, very important? Because patient will have a normal vision till the end. The central vision is affected at the last because the damage starts from the periphery. Okay? So what are the clinical features? Let us talk about clinical features. We will learn mainly the patient is complaining of headache and eye ache. That is the main complaint of the patient, headache and eye ache. Okay. Second point we will remember, vision is initially normal. So we can say visual acuity is normal in initial stages. What about color vision? Please keep in mind, normally in optic nerve pathology, the color vision is affected. There is a red-green defect, but exception is glaucoma. Glaucoma is an exception to the corneal rule. We will talk about corneal rule when I am discussing optics with you all. So just remember, color vision will not be affected here. Okay, so color vision is normal. Now, three salient features by which we diagnose and confirm the diagnosis of open angle glaucoma when there are these three salient features are there. First, IOP changes. Intraocular pressure changes. Number two, along with that, all three should be together, right? Along with that, fundus changes, right? Fundus changes means when we are talking about damage of optic nerve, there will be changes in optic nerve head. I just mentioned about what is cupping. So, we'll talk more in detail what is cupping in a short while. Then, what is third one? If there is a defect in the optic nerve, naturally there will be visual field defects, isn't it? So we will see changes and defects in the visual field, right? Now let us take one by one. First we talk about IOP changes. Give the heading IOP changes. What is the normal? This is the first question of your exam now. Put a Q there. What is the normal intraocular pressure? So normal pressure we all know is 10 to 21 millimeters of mercury. Next question. What is the normal diurnal variation? So in the whole day, what is the normal diurnal variation? Up to 5 millimeters of mercury. Okay, so anything between 5 to 8 mm, if there is deviation, we will just consider it as a suspect case. He may or may not be glaucomatous. We call it glaucoma suspect. And if it is more than 8 or more than 8 actually, then it is almost a definitive indication of this glaucoma. Okay? Are there some other factors by which IOP can be altered? Yeah, let's think about that. But before that, when you are saying, okay, before I talk about the other factors, when you are saying diurnal variation, there has been another question, when is it more, when is it less in the whole day? So please remember, it is more, M for M, more in morning. Okay? So remember, more in mornings. Why? Because cortisol level is more in the morning hours. In your body, the cortisol level is more in mornings. So this is the reason intraocular pressure is measured higher in the morning time. Write down some other factors which can cause short-term fluctuations. What are the other factors? This is interesting. You all have this idea. Let us just discuss it. If you've learned the glaucoma chapter, you've talked about provocative tests, right? So we can say that if one is your position which can alter the IOP, that means it is maximum when you are in a prone position. IOP is maximum, right? And then what next? Prone, then supine, and then comes your sitting. Supine is more than sitting. Exercise, it reduces intraocular pressure unless and until you are going for a mainly headstand, except that headstand. Otherwise, you will say exercise reduces IOP, decreases IOP, right? Okay. What about drinking a lot of water? That is the basis of water drinking test, which was done. Now they don't do it. We don't do it. So that was done for as a provocative test for open angle glaucoma. So we will say drinking water will also lead to increase in intraocular pressures. Okay. Next we talk about is, after this is, what are the other factors? The other factors apart from water drinking test or drinking water which is increasing the pressure is your GA drugs, right? So we can write down, even that can cause short-term fluctuation in the sense that under GA, when the pressure will decrease. So GA drugs may in IOP decreases. So do you realize in a patient, can you think of a child with congenital glaucoma? You can only assess the child and the detailed examination can be only done under GA. So you have to keep in mind that whatever intraocular pressure you are measuring is not totally reliable. Okay. But yes, except one thing, that is ketamine. It will not lower the pressure except ketamine. And of course steroids, that everybody knows. Do we need to mention? We can mention here, steroids increase the intraocular pressure. That also is causing fluctuations in the intraocular pressure. Now steroids, you know, the population has been divided as steroid responders, right? So steroid responders, where there is change in the intraocular pressure, if a person has change in IOP, we call them steroid responders. And this steroid responders, these people, we can divide it as mild responder, when the pressure change is anything less than 6 millimeters of mercury. Moderate responders are those from 6 millimeter to 15 millimeters of mercury, and severe steroid responders, these are the population where giving steroids the pressure rises differences more than 15 millimeters of mercury. We should totally avoid in severe cases of steroid responders, right? Okay, so these are some factors for the short term IOP fluctuation, right? When you know this much about the IOP, what are the other things that need mention here is, what is ocular hypertension? So ocular hypertension, the name itself is telling you, if I talk about the three salient features of open angle glaucoma, what were those? IOP changes, fundus changes, field effect. Now, when you say ocular hypertension, what we have to keep in mind, IOP is raised, but there is no damage of the optic nerve. It's the only raised IOP that I am finding, no damage in the optic nerve. That means fundus findings are not present. Okay? No fundus findings, no visual field effects. Good, I am happy, no damage till yet. But we consider these patients as ocular hypertensives because the pressure that is recorded is higher, right? Now, in these, how do you manage? Should I start any treatment in such a patient? Does it make any sense? Glaucoma treatment is a lifelong process. You cannot just start an anti-glaucoma without being very sure that the patient needs it or not. Just like diabetes, the patient has to take a medication throughout life. Got it? So, we will just see first, in the recent study, it has been concluded, okay, that is ocular hypertension study was done, and it has been concluded that there are a group of patients, there are some set of risk factors. If that is present, then I can treat this patient, though in a milder way than any open angle glaucoma patient. If those risk factors are not present, I am not going to start any treatment. So keep in mind, what are those risk factors? So what the risk factors, number one, any intraocular pressure of, if you are recording a pressures of so high as around 30. Now this is something worrisome. Number two, this patient has got a thin cornea, right? Thin cornea, in a thin cornea, I will just talk in tonometry, that the patients we are actually underestimating. That means the pressures can be even more. So thin cornea is where we are even underestimate the pressures. Either he has already a more pressure, even then I will start the treatment, or the patient has little higher pressure but there is thin cornea, which means I am already underestimating the intraocular pressures. Okay? If I am getting a fundus changes is prominent, like the cup disc ratio, again I'll talk very soon about it. That means, but there are no fundus changes in ocular hypertension, I just said. So it is confusing picture where we say normal cup disc ratio, if you are talking about, we consider less than equal to 0.3. I know you must be thinking cup disc ratio, what is ma'am talking about? Just give me 2 minutes, we'll come back to that. Note it down here. So the cup disc ratio, this is normal, right? This has been your exam question, put it here. I'll just come back to your cup disc ratio quickly in 2 minutes. But if it is more than 0.5 and we are noting more pressures, I can consider him as a high risk case. Okay, so these are high risk cases of ocular hypertension where pressures are more, cornea is thin, or even the CD ratio is around more than 0.5. In such cases, I will decide, okay, let me start the treatment. And as I said, the treatment will be the same as we will discuss for open angle, but in a less aggressive form. Take it? Okay. And what is normal tension glaucoma? Normal tension glaucoma means this time intraocular pressure is recorded normal within 21, but I do see the fundus changes present, field effects present, which means the damage is present, right? So definitely I have to take care and I have to start the treatment in this case, right? We'll talk about details of treatment later on. Now generally when I say NTG and when the pressures are normal, what did we learn here? Main factor is vascular theory, which means that the patient is having some less blood supply in the optic nerve. So you think with me, we are not mugging up anything logically. So in which patients can I get a finding of normal tension glaucoma? So patients can be like patients with nocturnal hypotension, right? Now this is a serious thing. So, and what can be the associations? Patient with nocturnal hypotension, right, like this. Second association could be sleep apnea patients, okay, and even migraine patients, migraine being very common, but migraine patients. So wherever there is some disturbance of the blood supply, these people are at a high risk of developing normal tension glaucoma, okay. And of course, you may also get a significant positive family history, okay, right. Then we talk about, after this, you know what is normal intraocular pressure, what are the diagonal variations or factors by which the IOP is fluctuating. We talked about ocular hypertension, we talked about normal tension glaucoma. Now how to measure the intraocular pressure? This is again important part for your PG entrance. IOP is measured by tonometry. Now when you say IOP is measured by tonometry, we will now further divide that this tonometry, which is the IOP measurement, broadly if you divide, it can be either indentation tonometry or it can be applanation tonometry. Indent, to really indent the cornea, digging in, right? So that is indentation. We already know the name, Schiot's tonometer. This is the only one name we will learn for indentation. Okay, we know what is indent. What is applanate? Applanate means to just touch and flatten. That is what is called applanation, right? So applanation tonometer, let us further divide it as variable force applanation tonometer or fixed force applanation tonometer. Now, when I say just touching and flattening is applanation, majority of the time, suppose we take example of this, how it is based. The whole applanation is based on Imbert-Fick law, which says that any pressure is equal to force upon area. Now here, when you say variable force, I am fixing the area. So I am writing here, area is fixed. In variable force, what is happening? Area is fixed. And that fixed area of the cornea, which you are just flattening or applanating, is around 3.06 millimeter diameter. That comes around 7.35 millimeter square of area. So just remember 3.06 millimeter diameter area. We are taking applanating, and of course the most common and which we use is this one. Please keep drawing whatever I am drawing along. This is what is Goldman. And what is very important for you to understand here, I'll be showing the slides, first lesson here, that when I'm digging in something, just imagine if the patient is lying here and you're putting the Schiot's tonometer and you're indenting the cornea. Do you realize you are indenting the cornea? Do you realize? See, this is your Schiot's and this is how we are indenting. So there are different weights which we put at this site. Okay, so and we can take multiple readings, right? It can be 5 grams, 7.5 gram, 2.5, 7.5, then 7.5 gram and so on. And whatever the needle position here, I am noting down, and then I am matching it with the card. What is that card known? Frieden. It is Frieden-Wald nomogram, okay, or chart. And from there we are taking the reading, our final IOP reading. Now what I want to discuss here is, do you realize that when you are indenting so much, the periphery of the cornea is also taking part in the whole process? And periphery is attached to the sclera at the limbus. So how much you are indenting will also depend on the scleral rigidity. If your sclera is soft, it will indent little more. If it is rigid, it will indent less. So keep this in mind, that the reading of Schiot's therefore is less reliable. Indentation is always less reliable than applanation. Reason what? Because, write down here, the reading depends on scleral rigidity of the patient. That is why this is less reliable. When you say scleral rigidity, do you realize something? When is the rigidity soft and when is it not soft? Of course, one I told you is in children, where you have less rigidity, it's a softer sclera. Apart from that, think yourself, if the patient is a myope, so myopia means long eye, thinning of the sclera, rigidity will be less. If your patient is a hypermetrope, again it is a shorter eye, thick sclera, rigidity will be more. So even your refractive status, according to whether your rigidity is less or more, the IOP reading is depending on that. Therefore, it is less reliable, and therefore applanation is considered the most reliable method. Okay? Okay. So this was about your Schiot's. That is why I hope you have made that diagram to make you understand that here the periphery of the cornea is not affected. Corneal diameter is 11.5 to 11.75, but I am only applanating 3.06 millimeters of the cornea, right? As you seen this is what is applanation tonometer. You are looking at. It consists of a double prism here. When you are putting in the eye, touching it, before that you have to put fluorescein dye, and when this touches your eye, we see two semicircles. Now this I again included, it's a repetition, but this was your exam question. That what is the investigation going on? So make it a Q and keep it in your mind. This is applanation tonometry. These are the two semicircles I see when it touches the cornea. Now what is my aim? So the knob, where is that knob? Let us see this. This knob I am talking about. So we are turning the knob in such a way that inner margin of both the semicircles just touch each other. Whatever reading I am getting, that is the reading of my applanation. Okay, so this is the what I'm talking about. When the two inner margins just touch each other, this reading is what is the correct, the reading at which I get this point is my correct intraocular pressure. Please remember, this is your Goldman applanation tonometer, which is a gold standard for IOP measurement. Is it that perfect? No. Even this has some disadvantage. And what is the disadvantage? Whatever I am measuring also depends on, please note down, central corneal thickness. So if this patient has a thick cornea, I am overestimating the, whatever is actual IOP, I am overestimating. CCT is central corneal thickness. And in a thick cornea, I am saying we overestimate the IOP, and when the cornea is thin, in a thin cornea, we will underestimate. Okay, that is why you just learned with me that any corneal thickness of less than 555 microns should be taken alarmingly. It means that whatever intraocular pressure you are measuring is not very accurate. Is it okay? Okay, so once we know this, let us also understand this, that when you say central corneal thickness is affecting the IOP, keep in mind 10 microns of change leads to 0.7 millimeters of mercury change. Okay, so let's note it. Let's write here. It depends on the central corneal thickness, and 10 microns change in central corneal thickness leads to 0.7 mmHg of IOP changes. This data is important and should be learned. Okay, so I just told you about, we are talking about variable force first. So a whole applanation is based on Imbert-Wick law. When I say variable force, it means my area is fixed. So amount of force that is needed to applanate that area will be directly proportional to the intraocular pressure. Now common sense, think yourself. If it is fixed force, now this time the force is fixed, so this time area is actually inversely proportional to the pressure. So this is what you have to know. Next, we have to know the different names and what are the questions asked accordingly. First, we are talking about, apart from Goldman, what are the other variable force? Write the list. So variable force tonometry, one I said is Goldman. There is a handheld version of Goldman, write down Perkins. You don't need to learn the list this way. I will let you know how you will learn. First, please note it down. Third is Dreger. Dreger. D-R-A-E-G-E-R. Okay. Dreger tonometer. Then write down Pulsar, Airpuff, Grolman's, ठीक है? Okay, then write down Tonopen, McKay-Mark, Rebound tonometer. All these names are variable force applanation. How to learn it? According to the questions asked. Okay, so first thing, important thing that we will note here, gold standard is of course Goldman. Even though the pressure reading is still varying with central corneal thickness, but we will understand here, even today this is the gold standard. Considered gold standard. And of course, one question which I have told you, it has been a repeated question, which is more reliable, applanation or indentation? What will you answer? It is applanation, because indentation depends on scleral rigidity. Okay, we come to the next. I said that handheld version is Perkins. For Dreger, you have to learn it measures wide range of IOP. Means too high and too low, it will not give unreliable results. So it is a wide range of IOP. It measures a wide range of IOP. That is 1 point for Dreger. Then which are the non-contacts? You just saw the Goldman, how we are touching the instrument to the cornea. Suppose I don't touch it. There can be risk of infections and other problems. So suppose I choose for a non-contact method. Non-contact, it is a puff of air by which I am acclimating. Okay, so what are the names? All these three. So this is another exam question. Right? So for non-contact, this is your non-contact names. Next question is, which tonometer is a choice for children and infants? So earlier the handheld Perkins was the answer, but today we will answer TonoPen. So both TonoPen and McKay-Mark, they first of all learn this, are based on the principle of both indentation with applanation. First point to remember. These are all cues, okay? So don't take it lightly. Both applanation and indentation. Second point, for infants, the choice will be TonoPen. Second would be choice after TonoPen would be, because TonoPen is the latest. McKay-Mark is an old name. I am going to choose TonoPen. And second would be Perkins for children. Right? Now, which tonometer, third question, can be used in irregular and scarred corneas? Again, TonoPen and McKay-Mark. But again, if I have to choose one, I will choose the latest one, TonoPen. So, TonoPen and McKay-Mark are based on both indentation and applanation, and these two can be used in scarred and irregular corneas. You have to remember the list something like this. Okay? Yeah. Another important question and interesting question. If a patient is using a bandaged contact lens, do you all know that? Bandaged contact lens is nothing but soft contact lens which I am using for therapeutic purpose. We will talk about it in cornea chapter. So if a patient is using bandaged contact lens, which tonometer? Again TonoPen. So you can be used even in bandaged contact lens patients. Right? Using BCL is bandaged contact lens. So that is another information for you all. But this one for infants, your exam question. This is your exam question, that is scarred and irregular corneas. And next exam question was their non-contact types. This is your exam question. The answer was pulsar in that question. Right? Then another exam question was, which tonometer can be used for self-measurement? I can measure my own IOP. Now your answer is rebound tonometer. Okay? So this is the next important question. Rebound tonometer can be used for, let me write. So rebound tonometer is used for self-measurement. Okay, this is again an exam question. It is used for self-measurement. You can call it as a home tonometer. Okay? Any other thing in the list I want to add? Transpalpebral, where I am not directly putting on the cornea, but eyes are closed and I am measuring. So one very simple method is your digital, isn't it? Where you are trying to know the IOP, whether the eyeball is looking firm or is it harder or is it soft. Just listen, then we will write. Okay, so one is your digital. What is the other? There are a few names you should know. One is diatal and one is proview. So let's note down number 10. Number 10 can be transpalpebral. We'll see the slides. That will be like a revision for you all. So a transpalpebral tonometer means that's why whenever you are doing a digital, keep in mind, we always ask the patient to look down so that I am not actually palpating over the tarsal plate. Otherwise, my conclusion or my finding will be wrong. Okay? So, one is your digital. Of course, we don't depend on digital so much. It's just a rough and a quick idea. So, digitally, with the fingers, I'm trying to find it out. It is that digital. I mean this one digital, right? Mechanic. Soft, or it could be firm, or it could be hard. We consider firm as a normal, okay? Firm consistency is considered the normal, or it could be hard. Otherwise, you please note the name diatom, and third you can note one more name, proview. An interesting fact, if your patient is actually having a keratoprosthesis, what is that? Okay, a quick idea. When the keratoplasty is unsuccessful, we are using some artificial material to maintain the transparency in the cornea. That is called keratoprosthesis. Again, we'll talk in the cornea chapter. So please let us, this is an interesting question here, that if there is a keratoprosthesis patients, which mode can be, which tonometry can be used is transpalpebral. Okay, so in keratoprosthesis. Done? Okay, so once we know this, we come to the next important thing. These were all what? Variable force. Now just be familiar with fixed force also. Write down what are the fixed force tonometers. I would like you to just know the name. One is Glaucoma and one is Baracker. Baracker can be used, generally used for before LASIK surgery also. So Baracker tonometer. Glaucoma and Baracker. Do you realize even the gold standard is also not reliable? The gold standard, even Goldman I am talking about, is depending on the central corneal thickness. So now we will learn a different heading on tonometers, which is the latest version, which is considered more reliable than Goldman, where the reading is not depending on central corneal thickness. So let us write it. If we talk about the latest one, we will say, let us learn like, one is a contact type, one is a non-contact type. The contact type is called Pascal's DCT. That is what is Pascal's DCT. When you say Pascal's DCT, DCT stands for Dynamic Contour Tonometry. It takes the contour of the cornea and the reading is not dependent on central corneal thickness. So it is definitely more reliable. And another interesting thing that you have to keep in mind, therefore, you can actually, this will be the choice of the instrument in patients with refractive surgeries and post-LASIK patients. Right? Which tonometer I will use? I will like to use the Pascal's. Goldman will not give a reliable reading. Because, why? Because the corneal thickness has been altered due to the refractive surgery. Okay? What is the non-contact type? Non-contact is Riker's ORA. What is ORA? ORA stands for Ocular Response Analyzer. ORA is Ocular Response Analyzer. Right? So when you say Ocular Response Analyzer, what it is all about? Please remember, this is not based on applanation. It is absolutely different principle of measuring the intraocular pressure, which is called corneal hysteresis. Okay, write down. ORA is based on corneal hysteresis. What is this corneal hysteresis? Let's understand. Again, it's a non-contact. It's a puff of air which is applanating the cornea. So when the cornea, due to the puff of air, is bending in, we are taking the pressure at which it gets applanated, but we also measure the pressure when it is coming back. Okay, so there are two applanation readings we are trying to take. One when it is the cornea is bending in, and one when the cornea is bending out, coming out. Got it? So let us write down. If you want to write down, please write here. So what is corneal hysteresis? We are actually taking the difference in these two readings. Okay, so we are actually measuring the biomechanical property of the cornea here. So it measures the biomechanical property of cornea. Where we are taking the difference of reading between when cornea applanates in, okay, you have understood, then you write applanates in, and during the air jet movement and the pressure at which it bends out. So what is the applanation reading and when it bends out. So if the difference is smaller, the risk of glaucoma is higher. That's what you have to know. So low value means more risk. Low value means more risk of progression of glaucoma. More risk of progression for glaucoma. Got it? So that was about corneal. Now let's look at the slides, then it will be more clear. So this one we started with Schwartz, right? This is Schwartz. This is your Goldman. After Goldman, this is the handheld version of Goldman, Perkins tonometer. This is your Perkins tonometer. It's already written for you here. This is your Drieger. Okay, so this is mainly similar to Perkins, but it has even a wider. Just remember, for Drieger, this has been your exam question. It has a wide range of to measure the IOP. Wide range of IOP may be measured, will be measured. Right? Then we talk about what is this? So handy, tono pen. What were the questions in tono pen? Let's revise here. So this is one which can be used in scarred and irregular corneas. Secondly, I told it can be used in infants, right? Yeah. And even it can be used in bandage contact lens. So 3 points. Infants, bandage contact lens, and irregular and scarred cornea. Important. This is your pulsar, non-contact. This one is your bus. So when you go in to an eye OPD, you are sitting first here before you meet the doctor, right? So this is your pulsar tonometer. To be very honest, it's not that reliable. If I have to really see the workup case of glaucoma, I should go for Goldman or maybe the latest ones. What is this? Common sense. You are stabilizing on the forehead and then measuring. Self-measurement, right? So this is your rebound tonometer. Again the same, rebound tonometer. So this is what is digital tonometry I'm talking about. Transpalpebral, right? We all know this is diaton and this is your ProView. Just be familiar with the name, nothing more. And as I told you, this is the keratoprosthesis patient. Okay, so it can be used in patients of keratoprosthesis. What did I tell you about Pascal's? You can use it in post-LASIK patients, right? Okay, let me see. Do we have Pascal's? Okay, which is this one? This is Makley-Kokov. We talked about variable force and fixed force, right? So this is a fixed force, Makley-Kokov. This is your Baraka tonometer, and this one is Pascal's. What are the points in Pascal? Because the Pascal's tonometry reading will not depend on CCT, so I can use in post-LASIK patients, and even I can use in keratoconus patients. Why to go for anything? I will see why I will not prefer Goldman, I mean to say, isn't it? So even in keratoconus patients or patients of refractive surgeries, I can use Pascal. So this is what is your, this is nothing but corneal hysteresis, which has been explained here, how by puff of air, this is the force which is being applied, and how the pressure sensor will measure the applanating pressure when the cornea is getting in and coming out. Okay, so this is how it looks like. This is ocular response analyzer. Again, remember, it is based on corneal hysteresis. Even if you remember this much, it's more than enough. So this is the chart. Okay, so what we see is applanation pressure 1 and applanation pressure 2. Right? So whatever pressure you're measuring, this difference is called, as I told you, hysteresis. And this is what we understood here, that when the difference is less, the risk is more. So we can depict it in a chart form. Too many details? Not required. Just know what is hysteresis. It measures the biomechanical property of the cornea. Now, so much about just tonometry, right? But all these are important exam questions, and it was very important for me to discuss this.